Hello, good evening. My name is Ruth Zaslansky. Thank you for the opportunity of presenting at the British-Ukrainian Symposium. I'm a pain neurophysiologist by training, working at the Department of Anesthesia and Intensive Care in a hospital in Jena, which is a city in the former east of Germany. My talk is one of a series of 4 about perioperative and post-traumatic pain and its management that will be given at this meeting. Professor Meissner gave one earlier today, and there will be 2 more talks tomorrow. So my charge in this talk is to describe some background regarding traumatic amputations and then burdens related to management of this type of pain. I think there are many burdens affecting both amputees and their families and also the clinicians caring for them. Since this is a meeting of anesthetists, my focus will generally be more on the acute, subacute phases of care rather than chronic. So, as I said, I will begin with some words on background related to traumatic amputations. And the first question would be, who might undergo a traumatic amputation? The cohort of people undergoing a non-traumatic amputation would be people with diabetes, peripheral arterial disease and infections, and less commonly cancer. These amputations generally occur in aging populations with existing other comorbidities such as cardiovascular disease, hypertension, or renal disease. Generally, one limb would be involved. In contrast, amputations related to trauma in civilians would be generally due to work-related or motor vehicle accidents. When it relates to combat, amputations are often caused by injuries such as occurring from blasts, penetrating objects, or crush injuries from improvised explosive devices, landmines, grenades, or artillery shells. In the military cohort, subjects would often be young men, generally fit and healthy, without pre-existing comorbidities. But in many of these cases, the primary injury doesn't occur in isolation. It's often accompanied by other complications caused by the trauma itself, such as post-traumatic brain injury, additional orthopedic or soft tissue damage. With time, infections and post-traumatic stress can occur. So we're really talking about patients with multi-trauma. I think it's important to add that whereas in the past this type of multi-trauma would be fatal for combat soldiers or civilians, either directly from the injury or due to infection or sepsis, but modern day advances in battlefield medicine and trauma resuscitation have led to increased survival of these subjects. And so these are now called unexpected survivors. And at least in the UK and US, about 5 to 10% of those severely injured individuals may require an amputation, which might involve more than one limb. The percentage compared to some years ago, which used to be something like 20%, has reduced over the years due to speedy evacuation and improved medical care. I understand the situation in Ukraine is different. It might take many hours or even days until severely injured individuals can receive care at the level they need. And so in Ukraine, the proportion of amputees from this cohort of experiencing severe injuries might be higher than 5 to 10%. But the implication of being an unexpected survivor is that there's now need to develop experience and expertise for the next level of care, how to care for these subjects beyond the acute phase of saving their lives. We'll see when we get to review burdens that there's a wide variety of physical and psychosocial issues that need to be addressed in these amputees. What about the prevalence of traumatic amputations? In the US, the Veterans Associations, the VA healthcare system, cares for about 100,000 amputees. This is data from about 2 to 3 years ago. Worldwide, as of 2017, about 60 million people were living with a limb amputation due to traumatic causes. In Ukraine, there are estimates of about 100,000 soldiers and civilians who have undergone an amputation since the full-scale war in February of 2022. Some of these people will have undergone a double, triple, and even quadruple amputation. However, accurate statistics are difficult to come by. But I think the bottom line is that in terms of numbers, this condition is certainly not insignificant, it is significant. So after the introduction about background related to traumatic amputations, what are the burdens associated with such an injury? I suggest there are many. As I said to start with, they affect the amputees, their family, and also care providers. The nature of the burdens will change with time, differing during the acute, subacute, and chronic phases of recovery. Some, such as pain and its management, will be relevant for both amputees and their healthcare providers. Other burdens, such as reduced quality of life, will probably be unique to patients and their families. On this slide, I've listed quite a few burdens, but we'll focus only on those with a red asterisk. And let's begin with pain and its management, as it is very central, obviously, to this condition. So what sort of pains are we talking about? Before I became acquainted with this topic, I was basically aware only of phantom limb pain. But I've learned that there's a considerable array of additional types of pain. So after the initial injury, there will be post-surgical pain. Professor Meiser discussed this topic of risk factors earlier on, and I will just mention again that preoperative pain is a risk factor for severe post-surgical pain. Guidelines of the US Army now recommend that management of pain should begin at the point of injury and not to wait until patients arrive to the first point of institutionalized care. When evacuation is fast, treatment with Actic, the fentanyl lollipop, might be relevant. The US Army also uses regional blocks when evacuation might take longer. Phantom limb pain, these would be painful sensations referred to the absent limb. This type of pain is neuropathic in nature due to damage to the nerves during trauma and surgery. It's commonly associated with functional changes in the peripheral and central nervous systems, but unfortunately, there's a lot of missing information or a lot of missing knowledge about how the mechanisms of this type of injury. It can start in the early hours after surgery, and there's discussion in the literature on how its character changes with time. Then we go on to residual limb pain or stump pain, pain in the remaining portion of the limb. It is nociceptive in nature, arising from inflammation, infection, or poor prosthetic fittings. It can be spontaneous, whether continuous or paroxysmal, or it can be evoked. Evoked, such as when a prosthesis is poorly fitting and it rubs against the stump. Additionally, it can be neuropathic due to neuromas sprouting from the cut nerve ends. Phantom limb pain and residual pain can be present in the same patient, in the same person at the same time. Then another types of pain would be musculoskeletal pain, initially after surgery, possibly from uncomfortable positions in bed, but in later weeks, musculoskeletal pain can arise from strains placed on different parts of the body during movement. The back, hips, and remaining limbs may develop pain due to altered biomechanics and overuse. Then we have complex regional pain syndrome, CRPS, and post-traumatic fibromyalgia. These are also types of pains that are typical of traumatic amputations. And lastly, anxiety, depression, post-traumatic stress disorder would be mental health conditions which will negatively reinforce the acute and chronic pains. So we're dealing with a complex patient who has multiple sources of pain and possibly other comorbidities such as brain injury and/or infections and/or anxiety and/or depression. And these pains are likely to change over time from being acute to chronic. Just to summarize the different types of pain, I thought this is an interesting quote from a paper by Tina Doshi and her colleagues, who work at the John Hopkins Hospital in the US and the Walter Reed National Military Center, so they're certainly exposed to soldiers. Stephen Cohen collaborates, is another author, and he collaborates with many clinicians in the Ukraine. And what do they emphasize? That post-amputation pain is not a disease, it's a syndrome representing a constellation, a lot or many signs and symptoms with different etiologies and mechanisms. There's an absence of pathogenomic biomarkers and wide-ranging responses to treatment. What about the prevalence of the principal types of pain that are typical of amputation and would generally be assessed in studies? These are findings from a systematic review and meta-analysis carried out by a group of clinical scientists at the Imperial College in the UK. They run the ADVANCE project. ADVANCE is unique in that it evaluates a group of amputees longitudinally over years from their injury, and they're evaluated for a large array of biopsychosocial aspects of traumatic pain and amputation. And the advanced team aim to learn how to treat those unexpected survivors, the ones I mentioned initially, beyond the acute phases of recovery. But in this review, Kuma and his colleagues relied on existing data from close to 15,000 amputees from 6 national armies. And what they found was that if we look at phantom limb pain, its pooled prevalence across this cohort of 15,000 veterans was about 57%. They found that the phantom limb pain was associated with residual limb pain and phantom limb sensation. Phantom limb sensations would be sensations in the phantom, but not painful. And the more distal amputation in upper limb amputations. Depression, anxiety, and PTSD are also associated with phantom limb pain. Residual limb pain, its prevalence is around 61%, and it is associated with higher intensity of lower back pain. And lastly, chronic neuropathic pain. Its prevalence is around 26%, but there's a large confidence interval across this cohort that was being assessed. And it is associated with high scores for pain catastrophizing, depression, anxiety, PTSD, and lower quality of life. Some of these signs and symptoms are certainly typical of neuropathic pain in many other conditions. One limitation of this data is that the assessments were carried out in these studies at single time points, and amputees were certainly at different phases of their injury. So this is a heterogeneous cohort. Hopefully the advanced cohorts, the information we gain from the advanced study will be more valid and reliable. What about the burden of rehabilitation after traumatic amputation? I found limited data about this topic, but this is data from the US. In one study, they found that fewer than 50% of subjects who had undergone a major limb amputation were ambulatory with a prosthesis by 1 year after surgery. In another study, fewer than 50% of amputees had returned to work by 7 years after a lower limb amputation. And lastly, the third study found that Army veterans with through knee or transfemoral amputations, quite a high proportion, reported they were fully disabled with mental health disabilities. So I think this indicates that traumatic amputation can certainly affect the quality of life of amputees. They may require long periods of rehabilitation, and this obviously places a heavy burden on themselves, on their families, and healthcare systems. Now, yet another burden, the burden of providing pain treatment that is effective. Despite the increasing options available to pain practitioners, the evidence supporting clinical use of any specific treatment remains limited. To the best of our knowledge, there is currently no standardized prevention or treatment recommendations which are based on high quality studies for any type of post-amputation pain. The most recent guidelines I found were created by the US Department of Veterans Affairs the VA, and the US Department of Defense. There's a 2024 version addressing lower limb amputation and a 2022 version addressing upper limb amputation. What is interesting about these clinical practice guidelines is that they aim to offer recommendations across the lifespan of a person with an amputation, from the time of the amputation to when the amputation is more established, and also they aim to address the spectrum of clinical conditions, surgery, rehabilitation, and also pain. So these guidelines are very thorough and they aim to look at the whole person. A side comment, as far as I gather, colleagues in Ukraine have told us that people are also working on developing clinical practice guidelines for use in Ukraine. I don't unfortunately have time to go into detail looking at the Veterans Associations and Department of Defense recommendations, but I wanted to share with you recommendations related to pharmacological pain management, which is so basic to any type of pain. And it's quite telling that these recommendations say there's insufficient evidence to recommend for or against any particular pharmacological intervention for the management of phantom and or residual limb pain. And there's a lot of text here, but I'll just read out the text that's in purple. If pharmacotherapy is offered, providers and patients should understand the uncertainties of the short and long-term effectiveness and safety of treatment. Another recommendation in these guidelines relates to mirror therapy, as it's considered a standard for treating amputation-related pains. This is another recommendation that the evidence for it is very low quality, but the committee reviewing the data for the VA and Department of Defense guidelines decided to include this because some amputees wish to receive non-pharmacological treatments. And they indicated that one of the reasons why they recommended it was that there's no evidence for harm for mirror therapy. I'm not sure I quite agree. I think one must qualify this statement, as I've seen a few publications indicating that mirror therapy can be associated with harms. Amputees can have emotional reactions associated with suddenly seeing the limb and then having it taken away. Other side effects might include increases in pain, dizziness, and nausea. And these reactions can be particularly strong in amputees with PTSD. And we're dealing with a cohort that is susceptible to PTSD. So this is a feature of mirror therapy which should not be ignored and certainly needs more study. Going back to the review carried out by Tina Doshi and her colleagues at the Johns Hopkins Hospital and Walter Reed National Military Center in the US, they assessed many pain treatments after traumatic amputations. And though they indicate there's no quality, they also indicate that there's no quality evidence recommending any treatment, they still go by the basic premise that the treatment should be multimodal. The strategy for treatment should be multimodal, including pharmacological agents, non-surgical procedures, surgery, complementary and integrative techniques to prevent, and obviously with the aim of preventing development of chronic amputation pain. So although there's currently no good evidence, there still needs to be attempts to focus on multimodal therapy. And as far as I understand, this approach is also followed in the Ukraine. I would like to share with you a section from an email we received from Professor Dmitro Dmitriev from the Vinnytsia National Medical University, and who is involved in numerous projects related to management of pain in injured soldiers in Ukraine. Professor Dmitriev wrote, as our clinical experience shows, effective pain control requires comprehensive multimodal approach. In routine practice, we use a wide range of interventional techniques. We also integrate non-pharmacological strategies, and we're developing and using our own digital applications to support pain assessment, self-management, and clinical decision-making. So certainly, also in Ukraine, the multimodal approach is prevalent and being used. Lack of information about pain and its treatment is probably another burden for people who were up to a very short time ago healthy and have suddenly lost a limb and finding themselves they're inactive in bed, but they've never been exposed or never been exposed to any serious healthcare problem. And so I would like to share with you very preliminary insights from a study we're carrying out in Ukraine to assess which information about pain and its management amputees would wish to have in the early phases after their injury, which would have helped them to overcome um, their pains. And this is a pilot study. This is pilot data that Professor Dmitriev obtained, and is free text that amputees who were at least 6 months after surgery wrote and shared with us. So the question was, thinking back to the first days and weeks of your recovery, which information about pain and its management would have been most helpful for you to receive? So one subject said it would have been useful to know that the pain can be long and severe, not only physically but also psychologically. Another subject said it was hard to tell. It would be good to have information telling me that this is normal because the pain and weakness weren't going away. Another question we asked them was what information you would have liked to receive about emotional well-being. One of the subjects said it would have been useful to have information how to cope with the fear and anxiety and intense emotions following an amputation. And this is echoed by another subject who said it would be useful to have information on how to cope with prolonged emotional distress and adjust to my new life. And lastly, a third subject said it would be useful to have information on how to stay positive. So the last section of this talk um, relates to assessing what do patients say about their pains and treatments. Based on a number of publications, it seems that phantom limb pain might be a topic that is difficult for physicians and amputees to discuss openly. And we've been finding references for this, addressing this topic, spanning from the First World War to wars in Vietnam, in Israel. I don't know how this is expressed in Ukraine. But here are some quotes from studies carried out in the UK. After the First World War, there was a large cohort of over 40,000 British veterans who underwent an amputation. And here is a quote from one of the physicians caring for them who said patients are often so afraid of their sanity being doubted if they talk about their phantom pain that they frequently only complain of the tender stump. So the tender stump is something very tangible, whereas obviously the phantom pain is intangible, and so they're afraid of addressing this. A patient said, I did not report sick because I did not expect the doctor to treat a ghost. And another quote, which I thought was interesting, this is a quote of a surgeon. It's not uncommon for a patient with a tender stump to mention that he also feels pain in the absent hand, but he will do this only after he's been under one's care and known the physician for a considerable length of time, and after he's learned that his complaints will not be scoffed at, his complaints will not be made fun of. Um, The same feelings were echoed by veterans who'd fought in the Vietnam War, saying that it was reported they would be, it was implied they were insane if they felt pain in a part that was no longer there. And again, respondents were frequently unwilling to risk their credibility and relations with their physician by discussing phantom limb pain. So this seems to be an elephant, possibly might be an elephant in the room. I think it's also interesting to know that veteran in focus groups said that pain management is a critical component of their care, but still, it's unfortunately still poorly managed. and they valued customers' approach to their different types of pain. And some patients value interventions that are non-pharmacological, such as mirror therapy. So to conclude, amputation, traumatic and non, is not an insignificant problem in terms of numbers. I suggest it's a significant problem in terms of numbers. Post-amputation pains are associated with suffering, reduction in health-related quality of life. There's challenges in rehabilitation, and it's certainly associated with mental health disorders. Unfortunately, there's still many gaps in knowledge of pain management. Current knowledge might allow for short-term survival, but we still need to develop knowledge of how to improve the quality of life in the long term. Thank you very much.